when I sent the abstract in, I basically just talked about the diversity in different tissues that we have and the different various types, whether you're working in human or veterinary or even plant in research. But bone specimens, whether it's human or veterinary, they require a special knowledge and understanding, particularly in the handling process, before you can even think about preparing it for visual examination or diagnosis. Unlike many other tissue specimens, a bone has its own special and intricate things that are going on based upon the nature of bone as opposed to soft tissue. Things have to be done. Things have to be done optimally and delicately before you even start the routine histological process. Otherwise, it's going to impact the pathologist's ability to make an accurate diagnosis. And this is very key when we talk about some types of bone diseases that are going on. So having said that, I want to go into the objectives on the next slide. The goals of the presentation are to understand the basic anatomy of bone and the complexity of the bone matrix. It's very important before you start working on this to understand the anatomy, and that's why I spent so much time in the first part of this presentation talking about bone anatomy. If it's not reversed or broken down so that you can apply routine histology to it, such as embedding, microtomy, the primary thing, you're going to have either a specimen or something that you turn over to the pathologist that is useless to him. If things are under decalcified, then the tissues are going to be shredded or destroyed, so forth. If it's over decalcified, they're not going to be able to see the details, the nuclear details and everything else in the tissue that they need to see to make this diagnosis. So it's a very keen point. Now, I bring this up because, well, let me move on to the next, and I'll talk about that, what I was going to say in a minute. The next goal is learn principles of decalcification and how density of bone, decalcifying agent, and time are all vital factors. And now what I was going to say about this is years ago, and even when I first started in histology, this wasn't, in my lab when I was being trained, it wasn't thought of as a science. I was just told to put it in this solution and check it later. And no one said anything about monitoring or timing and so forth. And when it was soft enough, you would know. And that was basically the science behind my initial learning of bones. So we need to really learn those principles of how to decalcify. And that further goes into understanding the anatomy first, so you can understand the density of the bone that you're decalcifying. The next goal is to understand the importance of monitoring the decalcification process and the end point determination, and that's just what I was mentioning, and I don't want to go into a lot of detail on that because we're going to discuss that later in the presentation. Learn to review and troubleshoot over and under decalcification artifacts, and then understand the differences and variability of decalcifying agents. And many of you are using these in your laboratory. So before I carry on, I just want to say that this is a basic workshop about one of the main fundamentals in histology. Many of you have taken this before in your training, and you might think this is somewhat elementary, but it's a good refresher to those who have been in the field for a long time, to those that are fairly new to the field. It's important. These are important aspects to know. Sometimes in our training nowadays, we don't have as many schools where they're teaching theory before you actually get into application, where you're actually doing the process. But to understand a little bit more about the theory of it, to understand the anatomy of the bone, the complexity of the bone, it will help you as a technologist when you start to encounter problems. It'll help you problem solving. It'll help you figure out what to do next if it's not going how it's supposed to go. You know, regular tissues, you fix it, you process it, you embed it, you section it, and so forth. But as I said before, bone specimens have their own certain things about them that make them a little bit different. So understanding the theory of that really helps. So now I'm just going to move into the next part of the program, which is let's talk about the anatomy of bone. Understanding the specimen type. What is bone? How is it the matrix formed and so forth? So we're going to talk about the density of the bone. That's a very key factor. or if you're going to be breaking something down, you can't just use a general universal standard for all bones. There's soft bone, there's compact bone. So those are things to be considered. And then also the proximity of the bone to other tissue types, because we don't want to use something that is so aggressive in decalcifying the bone that you start to destroy the surrounding tissue. You want to have something that keeps everything relatively in the same visual aspect, so the pathologist can see the normal state of the bone or the specimen, including the bone and the surrounding tissue. Optimal staining qualities. When bone is properly decalcified, what are the optimal staining qualities? What should you be seeing? And many times the technicians that do the decalcification, they're not the ones that are really checking this after the fact. So they never see sometimes if it's over decalcified. They'll know if it's under decalcified because they'll probably have trouble with it on the microtome. But over decalcification is something that oftentimes is never seen until it gets to the pathologist, and he'll have a problem with that. And so then we want to basically talk about the normative or the normal standards of routine decalcification, normal standards of breaking that specimen down. So the next slide that I want to show you is basically when we talk about bone. I remember when I was new in histology, I thought, well, bone is just something that is dead tissue. It's solid. It's just a structure or framework. But bone is actually living tissue. It's not petrified as I once thought. It is actually living tissue that is rebirthing itself, that is nourishing itself, that is breaking itself down as the bone continues to grow. Particularly when you're younger, this activity is accelerated. But even when you get older, the process still happens. Bone cells are constantly replaced, not at the same rate when you get older, and that is one of the main reasons why for someone elderly who has a broken bone, it takes much longer for them to heal because that process of regeneration has slowed down, but it's still ongoing actively all the time. So living cells and collagen fibers make up bone, and it's all within a dense calcified matrix. There are certain cells within the bone matrix that certain cells that emit or secrete the various different chemicals that make this matrix, this very dense matrix. And there are also collagen fibers in there. Well, the primary bone cells are osteocytes. These are living cells within the nuclei, which we're going to visualize in a second, but they are actually living cells that get trapped in this matrix. And this is one of the key things that you look for when you're QCing your decalcified specimen, because your osteocyte should have a very visible nuclei. If it's over decalcified, then that nuclei won't be there, and it's basically useless to the pathologist. So you have the living cell, which is osteocyte. Before that, you have osteoblasts, which are immature bone cells that have not yet matured into osteocytes, the living cells. And then after that, you have osteoclasts, which are the mature cells that actually start to break down bone tissue. So you have three different types of cells in bone, which are the osteoblasts, the osteocytes, and the osteoclasts. The next thing we're going to talk about is the concentric lamellae, which is how bone starts to deposit, how bone grows. And it's almost like when you think about a tree and you look at the cross-section of a tree and you see the rings in the tree that can help tell you the age of the tree. Well, concentric lamellae is different bone deposits being laid down over the vascular system of the bone and also around the matrix. So you'll see these concentric lamellae, which is just bone forming in a ring around it, and it will continue to replace itself. So there will be one concentric lamellae, and then on top of that there will be another concentric lamellae, and then another one. So that you develop these rings, and those are very visible when you're looking at a cross-section of bone specimen. And once again, you'll be able to notice these concentric lamellae by the osteocytes from the nuclear staining that are within them. So you can see the pattern of the circle around the vascular system in the bone. Now, the Haversian canal is what we're going to talk about too, and I'm going to show you an image in a second of all these different things I'm talking about. But the Haversian canal is basically the vascular system of the bone. Haversian canals are the primary vascular system within the bone that allow blood vessels and nerves to travel through and nourish the bone. So this is how the bone continues to replace itself, or nourish itself, and actually move away bone material that has been absorbed back into the body, that has been old bone cells that have been broken down and will be absorbed back into the body. It's blood and nutrient supply system. Then you have an external and an internal membrane, which is the periosteal lamellae, and that is covering their very outer layer. It's a very thin connective tissue sheet that covers the outer layer of the bone, and then an endosteal lamellae, which covers the inner layer of the bone, and that basically is the border between compact bone and then when you see the bone marrow material. So, and you can see all of these things that I just discussed. At the top of the image that I'm showing you, this is an image from Allison that is in one of the instructional texts for training. The periosteal lamellae is at the very top, and once again, you can notice that it is being formed in concentric layers all around. So it's not just one, but it continues to form, and that is showing you how the bone is continuing to grow and to continue to replace itself. So you have that periosteal lamellae. Now look on the very inner portion of that, and you'll see the endosteal lamellae, which is the inner connective tissue border. And then just to the left of that, you will see the bone marrow, the spongy bone. So as we look in the matrix part of this, and once again, this matrix is basically the osteoblasts that they form the bone cells, and then they secrete a substance called osteoid, which is an inorganic salt of calcium phosphate, and they're deposited by the osteoblast, and then actually that matrix just continues to develop into a cement-like matrix. It's mineralization, mainly calcium salts, and it becomes harder and harder in a thicker cement-like matrix. And that is how bone formation happens. Now, if you look at the image here, you see in the matrix these rings, and you see the vascular system going through there, and you can see the Haversian canal system, that is the vascular system that I spoke of. And so the Haversian canal system, it's the primary vascular system, as I mentioned before. It allows nutrients and blood to flow to and fro. But even within that, you have this system called the canaliculi, which are basically the system that actually goes in between these vessels in the Haversian canal, and these actually go to all the individual cells, the canaliculi. It allows nutrients to be passed to the osteocytes and provides for the elimination of waste products through the tissue. So when bone material is broken down, these canaliculi, this system actually channels those nutrients either going to the cell or the broken down bone material traveling away from the cell. So as you can see, this is a very active system. You see the capillaries that are within the concentric lamellae in the lower right portion of the image. Capillaries are in this system. The system that holds all of this is the Haversian canal system. You can't see the canaliculi until at the top to the left. You can see that it's almost like you see one osteocyte, which would be the darker spots in the circle. Those are osteocytes, and what you would see if you were looking at H&E, you would see a nuclei in each one of those osteocytes. The lacunae, which is still in the upper left, are the spaces where the osteocytes are. So this visual image, which we're going to see in real life histology preparation, it's a good way to look at this so you can understand how bone is formed, how it continues to develop, and how bone is actually replenished. So the next slide shows the variability in tissue profile. Now I just showed you an example of compact bone, which on this slide would be right in the center. And you can see here in the center image, you see the Haversian canal or the vascular tube like right in the center of this big ring. I don't know if you all can see my pointer or not, But I'm going with the center image right now, and these concentric lamellae, and so you can see this circular development here from how the bone is forming, and you can see like the smaller circle in the center. You can see the canaliculi here, or what connects this this lacunae, which is the hole or the space, to this lacunae that's connected by the canaliculi. You can see in the center here the vessel, and here all this whole area that I'm circling on the outside, this is actually part of the Haversian canal system, and you have all these different vessels that are coming up through the bone, and they continue to deposit bone material around them in these concentric lamellae, which is what I was talking about before. Now, individually, as I said before, these are lacunae which hold the osteocyte. Now, the image on the left, which is where my pointer is now, is actually breast tissue. And sometimes there's calcifications on breast tissue. So the point I'm trying to make with this is that these calcifications, they can be somewhat problematic when you're doing microtomy. You have to be very, very careful because you don't want to rupture or destroy or distort the tissue cutting through that. But certainly there is a stronger consideration for some mild calcifications here as opposed to the picture in the center, which is a very dense cement-like matrix. So this just brings up the point that you have to really understand this when you're going into decalcification if you want to do it optimally. The picture on the right is actually lung tissue, and sometimes there's calcifications in lung tissue for whatever reason or pathology. But you see how delicate these alveoli sacs are, but take it you have some mild calcification in there. Well, you certainly can't use a very, very aggressive decalcifier for this because it will destroy these thin alveoli membranes. And if you use something too soft, then you'll shred the tissue as you go to try to attempt microtomy because there's still calcifications in that. So all of this thought really has to go into breaking down this matrix that I talked about. But basically, it's all the same concept where you have bone cells that are cementing, that are secreting this cement-like matrix. Now, the next slide, I have two bigger images now. One on the left is the same image that I showed you of the lung specimen, just to show you how delicate those alveoli sacs are in the lung. You have calcifications in there sometimes, and we have to be the scientists that we are to figure out how to prepare that tissue so that we give the pathologist a visual picture just like this with no distortion. On the picture on the right, you have basically a different type of bone specimen. It looks more petrified. It looks almost spongy, something like petrified sponge. But this also is something that we might, when in some kind of bone diseases, that doctors might want to look at, and we have to be able to section that micro thin sections, 4 or 5 microns, preferably 4, so that the doctor can see this at a cellular layer. So now we're going to be talking about the various different bone types, and the two primary types. The first one is cortical bone, and it's mainly what I've been discussing all this time now with the hard, dense cement matrix. This is the image that I showed in the illustration by Allison, which shows the bone with the canaliculi and with the Haversian canal and the concentric rings and so forth. This is the kind of bone that we're talking about now. It's called compact bone because it's a very dense matrix. We see this in long bones such as the leg bones or the arm, the bones in the arms, skull, femur head, even in the teeth. Now, going back to looking at the long bones of the body, remember, especially for the youth, this rebirth or regeneration of bone is very active because, of course, kids are growing constantly. And so we see this, a lot of activity in bone regeneration, bone growth, bone birth, really in these long bones. And do a lot of studies and research, and you can actually use that as an example because I don't think that there's any better example in the body than either the long bones or like the fingers to study to see how bone continues to develop. But even in the thin bone plates, like the skull, which can easily be damaged or ruptured by injury to the head or something like that, even in those thin plates, this is cortical bone. This is compact bone. It just isn't as packed and dense because it has a different function or purpose, unlike long bones of the body, which are mainly for support. So then femur heads, of course, and I mentioned teeth. Now these require, when you're working with them, stronger decalcification solutions. And so I did mention this down at the bottom. We're going to talk about this later, which is the hydrochloric acid. It's pretty much the strongest form because it will help break this type of bone down. If you use a lesser aggressive decalcifier, it's going to take longer. It'll take more solution changes. And for routine practical histology, it just takes too long. So you have to basically look at what you're going to use. Nitric acid is another very strong decalcifier. Oftentimes that's used in dental decalcification. But the key thing is for this type of hard, compact, dense bone, you typically need a strong decalcifying agent for that. I'm going to go to the next slide, which you should see anatomy of bone. Now here's a closer shot of a compact bone, which is kind of like the image that I just showed you before. It shows you the concentric lamellae. It shows you the ring pattern. It shows you the canaliculi. It shows you the haversian canal where my pointer here is pointing at right now. This would be where the osteocytes are. They would be within these lacunae, or these dark, looks like spots, but you'd be able to visualize them, as I said before, through the nuclear staining. And here you see this is where the vascular system is, the vessels. And this is basically compact bone type of tissue. You have the compact bone, which is very dense, and now you have the cancellous bone, what's called cancellous, which is spongy or trabecular bone. Now, as it says here, these are thin, bony trabeculi. These are thin plates. One of the most common examples that we see of this are in bone marrow specimens. Very thin. They're almost like islands or these trabeculi that run through the bone marrow. But it's very important when you're doing decalcification to keep this in consideration, how you would decalcify this differently, because there is a lot of hematopoietic tissue, blood cells that give rise to blood cells that the doctors are looking for when they're doing bone studies, because basically they're just looking at the development of any kind of cancer and so forth. So they really need to be able to see those, and as I said before, over decalcification will destroy those staining properties in those cells. So the hematopoietic tissue you see here, the third thing that's very key in cancellous bone or spongy or trabecular, and then the nuclear detail in the cells, critical for diagnosis, bone marrow biopsies. Now this is the key thing. And when we talk about bone marrow, you have your clot, which is basically just blood, and then you have your core. And I was in the lab once where, because of the LIS system, the lab information system, it did not distinguish between clot and core. So here we have the processors set for bone marrows to do short run cycles, and also our decalcification process was set for that. But the clot would require a lot more processing time, and we quite often, until this problem was corrected, had to go back and reprocess the clot because it basically was on a cycle that was more intended for the core. The core, basically, the bone marrow core is still bone, but it's a very delicate and very thin bone matrix. So you'll see different types of decalcifying solutions. Before I get into that, I want to also give you an example of the breastplate, the sternum, which most people pound on their breast or their chest, and it feels a lot more dense and hard than something very thin and trabecular, like we spoke of before. But it is. The sternum is basically spongy bone, cancellous bone, not like the compact bone. These require weaker acid solutions. Formic acid, EDTA, which is a chelating agent. These are softer, more manageable solutions to use. And so oftentimes, when you're working with tissues like this or specimens like this, those will be used instead of that, instead of the more the aggressive materials that we talked about. Now let's move on and look at this again in the picture. And I keep showing you these because I spend a lot of time on anatomy, but we're going to go through this very quick. Just another image of things that I showed you before. But now look on this image where you'll see on the right, you'll see number 9 in this image, and I think this is from DeFior's atlas. You see the osteocytes on number 9, and now you can see the blue staining nuclei in each one of these cells, which is actually within this lacunae, or this circle, this white circle that I mentioned before. You see, this is bone marrow. So you see below that number 10, you see a lot of the adipose cells, the fat tissue, and then the number 11 before that, you see the hematopoietic tissues, which is what doctors really want to focus on when they're looking at this. And you can see the nuclear staining in that, the blue staining. So this had to be done very delicately and with a lot of care and monitoring. So I like to use this example to show across the diagram. You see number 6, you see the trabecular bones. These are thin, almost like peninsulas or islands running through the bone marrow. And once again, a good way to distinguish whether you have optimal decalcification is to look at those cells within this bone and see if they're still exhibiting good nuclear staining. All right, the next slide is the anatomy of spongy bone, cancellous bone. Just showed you that in the image that we showed you, but this is what it really looks like in histological preparation. You see this trabeculi running through here, and you also see in this image the hematopoietic cells. Now in this image, and I think it's just because of the image taking, you don't really see any nuclear staining, but I think that's just the image. This wasn't an example of over-decalcification, but it's just to show you the visualization of the morphology. So here is a very good example of bone marrow with the trabecular bone inside of it. Now, I actually did this years ago when I was working on researching a microwave decalcification project. And normally, the accelerated heat is something that you would not want to do on bone marrow because it heats it up so fast, it's hard to control it. But with the right decalcifier, you can actually do something like this. But whether this was done with a microwave method or through a normal method, these are the results that you want to see. You can see the concentric rings going around here. You can very well see the lacunae, these white vacuoles or surfaces here. You can see the osteocytes inside with their dark blue nuclear staining. Within the vascular system, this big white circle, you can actually see the hematopoietic cells. This is in the vascular system. So this gives you a very good example of what you want to see. Not only can you see the osteocytes, and not only can you see the vascular canal, but this preparation was done very well because you can see the delicate layers of bone that has been laying down around this haversian canal in the center. These circles that are going around it, this is how bone continually grows and develops. It just continues to put layer on top of layer on top of layer. And I gave you the analogy before of a tree, the concentric rings in a tree. So the next slide is basically showing the same thing, just a closer shot. Look at the nuclear staining and the osteocytes. Next slide, basically the same thing, a closer shot. You can get a very good image of the lacunae that are housing the osteocytes and the nuclei of the osteocytes. And again, the concentric lamellae of the rings as the bone matrix is being laid down continually. And this last slide here, I know you're saying, great, we've seen enough. But this is the last slide that I'm going to show you of this bone marrow, but I really wanted to show you this because the preparation on this was pretty optimal. You see the fat adipose cells, tissue around this island or this river or peninsula. You see within this bone cell, you can see in the center here the layers of bone as it's laid down. They look like long patterns or long lines going through there. You can still see the nuclear staining, and so very delicate material. Very good microtomy that was done on this after the calcifying, and a very good optimal decalcification process. Now, this sounds simple, but this really has to be closely monitored, particularly with bone marrow. And I emphasize this because, as I said, when I was first trained, this wasn't a science. Someone just told me, well, put it in there, and then when it's soft or you can bend it, you can take it out. I didn't learn till later about the specifics about the staining patterns and so forth. But this is the kind of information that the older techs that are in the audience, or excuse me, more senior technicians that are in the audience, need to be impressing upon the younger, new generation techs that come up because they don't always get this. Like I said, there's no schools, so there's less schools now. A lot of the training that we do is online, but they will benefit from your experience having worked with these type of tissues. And these things are what we need to show them So they have to understand why it's important to monitor the specimens. Next slide, methods of decalcification. And I wanted to, before we really got into that, talk about decalcification, just in essence about, mainly some considerations about it. We're really talking about, we talked about the matrix being laid down. Well, these osseous sites that I mentioned, they secrete calcium ions in the matrix with minerals that are also deposited in there. This matrix forms into a cement-like structure. Well, when we talk about decalcifying, the first thing that we're talking about doing is the calcium ions in the matrix are being broken down. So that's the main process. Whatever solution you're going to use, it's going to affect those calcium ions, and it's going to break those down in that matrix, and thus eventually making the matrix a lot more soft and pliable. So they draw them out, and usually in a solution that you have or whatever method, it draws them out of the bone. And once those calcium ions are drawn out of the bone, then the bone becomes softer. So the bone material and draws it out into the solution. So you have more calcium salts in the solution that's being drawn out of the bone material. As more calcium salts are broken down and drawn into the solution, the tissue becomes more pliable. Now, one primary thing to remember is as these calcium salts are being drawn out, the solution becomes saturated with basically calcium. And the more the solution becomes saturated with calcium, the less effective it is going to be as a decalcifier. So this is why we have to monitor this, and we have to frequently change the solution, especially if you're talking about decalcifying a compact or dense bone. If you're talking about just a bone marrow that has very thin, delicate bone plates, then you probably don't need to really worry about that. But when we're talking about doing femur heads or long bones, there's probably going to require one or two changes of decalcifying agent, just so you can continue to monitor it. When it starts slowing down the decalcification process, you can't really determine, it's more difficult to determine the end process. And we're going to talk about the end process in a minute. So let's go back to talking about the methods of breaking down this material, this matrix, cement-like matrix material. So one method is electrolysis, where you have in the solution of hydrochloric and formic acid solution, you have these electrodes, positive and negative, within a solution, and they will slowly draw the ions out just by the method of electrolysis. They will draw those ions out into the HCl and formic acid solution. And very slow. This is why it's not really practical for histology purposes. It's a very slow process, but in research, this is used quite effectively. The next is chelating agents, which are organic compounds that they bind with the calcium ion and slowly draw them out, the calcium and the calcium salts out of the specimen, once again into the solution. This is extremely slow, and typically chelating agents by themselves are not practical for routine histology. But many times it's used as a buffer or a softening agent for a more aggressive decalcifying agent. We see acids. This is the most common form in routine histology, most aggressive form of decalcification also, but where the calcium ions are drawn out of the tissue through the acid solution. It can be moderate to fast in the method, moderately fast to fast, but it is the quickest way to draw them out. Now, once again, you're drawing this out very fast. You don't want to go past the point of stopping the process, so you have to monitor these closely. And some of the strongest ones are hydrochloric and nitric. Formic would be a milder form, and so sometimes you will see hydrochloric and the EDTA, which I mentioned above that, used together because the hydrochloric is very aggressive, and the chelating agent of the EDTA will slow that down and make it a lot more controllable. Here's some examples of decalcifier solutions that are used, and this is just one company, has Decal 1 and Decal 2. And formalin and formic acids are actually used in this, and it fixes the tissue and decalcifies it at the same time. The Decal 2 has a special consideration. It's hydrochloric acid and EDTA, which is what I mentioned before. The hydrochloric acid is much more aggressive, but then the EDTA is a buffering or softening agent. is stronger. Now, one thing about using hydrochloric acid in decalcifying solution, you have to remember, and I wanted to mention this before, but I wanted to wait until I started talking about HCl. When you're using HCl in any kind of decalcifier, you have to remember to thoroughly rinse the specimen. Well, you would do that anyway after you stop your decalcification process, but particularly with those decalcifying agents that have HCl, because HCl, hydrochloric acid, will actually, in the present, mixed with formalin, will form a solution called bischloromethyl ether, which is a carcinogen. And so if you're working with this and you haven't really rinsed it, you're going to start breathing these vapors, and it's very caustic, and it's very dangerous for you to be breathing that. So you want to rinse that out very thoroughly before you put it into formalin or the tissue processor. So I was mentioning about bischloromethyl ether, and very important to rinse, if you're using HCl or any kind, but particularly HCl, rinse that specimen thoroughly before you move on after the decalcifying process. So here is like the two main methods, but this shows you how a commercial vendor will use something that actually fixes and decals at the same time. The old method of doing this was they would decalcify it first, actually fix it first, and then decalcify it, and then put it into the processors. But this system here with a softer decal, you can do both at the same time. Now, this is probably going to be more applicable for some of the softer bones that you will use. Next slide I'm going to show you is another fixative decalcifier. So for smaller specimens, delicate specimens, or calcification, formalin, formic acid, you want to use them 20x volume of specimen. For smaller specimens, you want to basically use this in 2 to 4 hours, but you want to monitor this. This is basically for something like needle biopsies, or even the calcification in the breast or the lung tissue. One thing that you want to do is you want to control this. So you want to make sure that you continue to agitate or swirl the container that it's in, because that will promote penetration and enhance your process, instead of just sitting it in there and walking away and just going back maybe an hour later and checking it. Every time you go past that, you should try to swirl it, and you want to change after the first 2 hours. So next is rapid decalcifiers for larger specimens, and as I mentioned before, HCl and EDTA. EDTA is put into a lot of the hydrochloric acid decalcifiers now because it's just so aggressive. You do need to fix it in formalin first, because cells will continue to autolyze, and you don't want to start using decalcifiers if the cells are already autolyzed and destroyed. The doctor's still not going to be able to see what he needs to see, the pathologist. So previous fixation necessary, you still want to use it at a 20x volume to specimen. Gross not more than 1 centimeter. If the bone specimen, such as a long bone or femur head, is very thick, you won't have the decalcifier penetrating enough to react with the inner portion of the tissue. Change after the first 2 hours. Continue to swirl. If it's a very, very dense bone specimen, you probably can get by with not changing in 2 hours, as long as you're continuing to swirl the solution. You can do 2 to 4 hours. Here are some examples of decalcifying solutions that are on the market, and certainly we're not promoting any one of these. All of these are very fine for specific applications. Calex, Osteosoft, RDO, very aggressive, very strong, but very effective. When you're talking about long bones or femur heads and so forth like that, it still has to be monitored. Super decal, stat decal, and they started coming out with these immunocal, these decalcifying agents that were very good and applicable for using for immunohistochemistry. Traditionally, it was thought originally that you could not do in immunohistochemistry studies on tissues that had been decalcified because of the acid. The acid would destroy the antigen or the antigenicity. So you would basically get false negatives when you did your immunostain, because the decalcifying solution had destroyed it. But they came out with products, and there are more products than this out, called immunocal, that were designed specifically, and mainly this is probably formic acid and EDTA or things like that, to be very mildly aggressive, to be easy to control, and to maintain or the antigenicity within the cell. That's another example. So let's talk about endpoint determination. How do you determine at the end of the process. This quote from Lee G. Luna says that the most important consideration and the one receiving the least attention is the removal of calcified specimens from fluids immediately after complete decalcification is accomplished. If this is not done, the chances of good staining reactions are reduced 10%. For every 2 hours, the tissue remains in decalcifying solution. This is very significant, 10% reduction on nuclear staining, and that will significantly impact the pathologist's ability to diagnose bone cases. It says it must be recognized that 90% of the poor staining qualities demonstrated in the decalcified tissue is due to this one factor. So next slide, I'm going to show you some quick examples as we come to the close of the presentation. Here is a fixative decalcifier, and you can tell it was done very well because there's a lot of nuclear staining in the hematopoietic tissue. This is a bone marrow slide, same decalcifier, and a bone marrow specimen. You don't really see any trabeculi here, but it's just all hematopoietic tissue, which is what the pathologist really wants to see. Next slide, rapid decalcifier. Usually you would not use this in bone marrow, but if you can be controlled if you monitor it closely. One of the products that I mentioned, the RDO, it was said when I was new in histology, don't use that for bone marrow, but it can be used, even though it's HCl based. So here you see the decalcifier still maintaining hematopoietic specimen. Here, this beautiful picture of cortical bone. It looks like something in space science or something like that. But you can see the material here. You can see the nuclear staining in the cells. Now in the center, you see this dark blue, and that's indicative of an area that is not as optimally decalcified, and it will pick up this heavy, dense staining pattern from the hematoxylin. And so that's indicative of areas that are not as optimally calcified, but it's still a very effective slide to use and a very pretty picture to see. So next is rapid decalcification on trabecular bone. So once again, one of those very, very strong, aggressive not-hematoxylin decalcifiers. Next, let's talk about over-decalcification. Now here you see a total loss of basophilic staining, no nuclear staining at all. This was left in the material as a bone marrow specimen, left in the material much too long. The next slide is also over decalcification, and you can see the trabeculi. Within that bone plate, you just see the lacunae, these spaces. You don't see any nuclear staining in the osteocyte. Also in the hematopoietic tissues, you don't see any staining in that also. Now I want to show you now under decalcification. What if you take it out too soon? Now this happens quite often in laboratories when you have lab assistants or something like that who are not connected or in tuned or working with or communicating with the histology lab. And of course, the lab assistants always get blamed for this. But on the far left of the slide, you see the hematopoietic cells within the canal system. And they're showing good nuclear staining. But here in the center, in this bone plate, you see the very dark, dense pickup of the hematoxylin, and that shows areas that have not been fully decalcified. Now you see this is under decalcified, and now you see under decalcified using a surface decal. When you just put it mildly on the, you use a gauze and you just put it on the block as you have it faced off, and it sits there. Or you take the block out and you put it into decal solution just for a couple of minutes. It will allow you to get a good section, only like 1 or 2 sections of that surface, so you can still pass this on to the pathologist. And this is just a surface decal technique when you have something like this, the under decalcification. So as I get to a close, I want to actually get to this point where I'm showing you this bone marrow core, this trabecular core. Once again, this slide you've seen a million times. So standard protocol, I'm going to give you this very quickly. Standard protocol for bone marrow, 2 to 4 hour fixation from time of grossing and formalin, and then continue to swirl the container when you put it into the decal solution. 1 to 2 hours, monitor it closely, swirl, rinse for 5 minutes after you finish, and place in formalin for processor. Standardized protocol for compact bone, cut the bone in approximately 5 millimeters. It may require a second grossing because sometimes the bone is just so big that you have to gross it twice. Fixation, 4 to 6 hours. You can usually get away with 4 hours if you've done it at 5 millimeters. Swirl the container, decalcification. We're talking about some of the stronger decalcifiers here. 2 to 4 hours, monitor it closely, swirl the container, check the end point. If it's not ready, you continue the process for 1 or 2 hours more, and you rinse for 5 minutes, as we said before. Very specific. You have to set timers for these. You can't just walk away and, oh, I forgot about it. You need to set timers to monitor it closely. Bone marrow protocol for the clot, the aspirate, because you can't treat that the same way you would a core. Gross and thin sections, 3 to 5 millimeters. Fix 2 to 6 hours from the time of grossing. Swirl, as I mentioned before, no decalcification, and then process. Now, this 2 to 6 hours, this is very critical because if it's not properly fixed, you're going to get a clot that's actually going to explode on your water bath, and you won't be able to get a good section. So I want to end up by showing you why it's important, because this is what the patient has to go through in the process of obtaining a bone marrow core, the numbing process, and this is very painful. Aspiration of liquid in the bone marrow, capping the probe, and then this is what they see, what you see in the center here. This is what they're pulling out and extracting through the needle. And then here's the core, as you see on the lower right. Why is this so important? Because, as I said before, this is a very painful process. And even though they use anesthesia and surface deadening and so forth, it's still painful. So imagine this with children who have some type of degenerative bone disease or whatever, and them having to go through this. So it behooves the technologists to be as professional as they can when they're handling these specimens, because of what the patient had to go through. And so I'm coming to the end of my presentation now, and I want to leave a few minutes for questions if we have. But I want to thank you all for attending. Here are my references that I used, and I'm going to move to the slide that Josh wants me to end on. And I want to say thank you all for your attendance and your commitment to continue your growth and development. And I'm going to turn the rest of the presentation over to Josh. Thank you very much.